Okay. Hi, everyone. My name is Dr. Mark Ettensohn, and I'm happy to finally be able to live stream to you today. StreamYard, the platform that I'm using, said that they wouldn't let me do it, that resource use was too high and I needed to wait. So anyway, here I am. I was starting to fret. Welcome, everyone who's here. Just to introduce myself one more time, just in case folks didn't hear it, because sometimes the stream doesn't start right away. My name is Dr. Mark Ettensohn. I'm a clinical psychologist specializing in the assessment and treatment of pathological narcissism and NPD, or narcissistic personality disorder. And I'm here today to discuss all things related to narcissism and NPD and personality disorders and identity and relational and emotional development. So thank you so much for being here today, and I'm excited to get started. I see there's already a few questions over here, and let me see. So hi, everyone who's saying hi. Chrisen Gundry, welcome. I am not familiar with Dr. George Simon, and I don't. Maybe I should be if he's been in practice for as long as you say, and if he's written several books. I've come across him, and I'm just not recalling it. I'm gonna look him up real quick just to see. Yeah, no, I'm not familiar with him, but I will. I'll check it out. Thanks for the recommendation. Okay, Mega Coffee 96 says hello there. Hi. I love Yeshua 1992. Hello. Okay. Let's see. Nepusto says, hi, I listened to Kernberg's lecture that narcissism with hypochondria gives minimal chances for recovery. And during treatment, the projection switches to the therapist. A patient becomes very paranoid. And then it looks like the question continues, including psychotic features up to a chronic psychotic. Treatment must be stopped. You have a video about hypochondria and NPD. What do you think about it, sir? Well, I'm not familiar with that specific interview from Kernberg. Typically, I agree with most of the things Kernberg has to say, although I don't know that I'm 100% on board with sort of the core of his conceptualization of NPD, and I know that probably sounds somewhat internally inconsistent on my part. Kernberg's conceptualization of pathological narcissism hinges around the idea of primitive pathological rage or aggression sitting at the very heart of the personality. A simple way to kind of conceptualize it that I've used before is that Kernberg's is a dysfunction model, whereas Kohut's is a deficit model, right? So in Kohut's conceptualization, somebody who's sort of developing normally, but kind of gets stuck because the early environment doesn't provide them with the self-object resources that they need, gets stuck using developmentally immature coping, essentially. Whereas for Kernberg, a similar thing happens, but the infant essentially makes a pathological adaptation where the infant fuses together their ego ideal, which is like their ideal self, with their sort of fantasy of an ideal object that would meet all of their needs perfectly, and their kind of real self. So all three of those get fused together into the same construct. And that creates a kind of an insulated internal realm that is really difficult to penetrate, and it's resistant to empathy, as you might imagine, and things like that. So I don't go that far with Kernberg. I appreciate a good psychoanalytic formulation as much as the next person, but I tend to view pathological narcissism more in terms of what Kohut is describing, and less in terms of like that fundamental early pathological adaptation that Kernberg's positing. I like a lot of stuff about Kernberg's theories, though. In particular, I make heavy use of his ideas about personality organization. So, okay, all that being said, I think when he's talking about hypochondria, first of all, Kernberg considers hypochondria to be kind of part and parcel to pathological narcissism. I have a video that discusses this. It has to do with like primitive anxieties, primitive paranoid anxieties about loss of self or the dissolution of self-experience that kind of get funneled in a very concrete way into preoccupations about like physical integrity. And it becomes kind of its own like anxious, ruminative, or obsessional process where the person is really concerned about loss of control and kind of coming apart and annihilation of self-experience, but they're kind of dealing with it in a very concrete way. By focusing on illness and the am I okay? Essentially, it's am I okay? Am I okay? Am I okay? Am I losing control? But it's kind of attached concretely to physical integrity. If he's saying that can be psychotic, I agree that it can include a psychotic element to it. I don't know what he might be saying about like treatment must be stopped. I would disagree with that if that's what he's saying, unless there's some piece of it that I'm kind of not getting. But thanks for the question. I hope I've addressed your question there. Yeah. Thanks for being here. Okay. Let's see. This individual says that they read my book and it helped them a lot. Thanks for that. Thanks for letting me know. For anybody who doesn't know, I have a book about narcissism called Unmasking Narcissism, a guide to understanding the narcissist in your life. It's right up there. That's the one with the yellow cover. It's written from a compassionate perspective. And I really... like it's part of my approach to these issues to see them as variations on normal human experience, and to really try to highlight and hold the fundamental humanity of all involved, and that's really where I was coming from when I wrote that book. So I'm glad it was helpful for you, and thanks for letting me know. Okay, Compass and Bridge. Doc, please tell, are there cases in your practice and in the professional literature that NPD patients were able to build healthy relationships and families after and thanks to therapy? If yes, what are the features? Yeah, actually, I've got a video coming out next week where I'm discussing this very thing, and a very recent landmark study, essentially, that provides unambiguous, kind of incontrovertible evidence that full remission from NPD is possible. And it was just published late last year, so I'm pretty excited about it. I don't want to spill the beans on it entirely because I want people to watch the video, but stay tuned. It should be coming out Wednesday of next week. and I'm really excited to see if it makes a splash, because I think it should. And I think that for too long we've kind of languished, all of us collectively, in this absence of really strong empirical data that establishes, that NPD is treatable, and that it is possible to make significant, meaningful change when you've got that diagnosis. So, you're asking about building healthy relationships in that study that the video is about. The individuals, all of them, by the end of the study, save one, I think, were involved in healthy and sustained romantic relationships. And almost none of them were at the beginning of the study. I think it's possible. I've seen it in my own practice, but now there is data that also demonstrates it. So thank you so much for the question, and stay tuned for that video. Like I said, Wednesday next week. All right. This individual, then I'm not going to try to say that name, Moff. Hi, Doc. Are there any disorders where the mechanism of defense is very similar to narcissism or NPD, but at the same time is not NPD itself? Yeah, a lot of time. So I do these personality assessments, and they're pretty involved processes. I've talked about them before during my live streams. They take a couple of months to complete, so it's no small potatoes, right? I'm not like just talking to somebody for an hour and then like giving them a diagnosis. This is a comprehensive personality assessment. It's not just looking at whether or not they have NPD. It's looking at, is there the presence of personality disorder? If so, what are the main features, right? So is it borderline? Is it narcissistic? Is it something else? And if not, okay, well, what are the dominant personality patterns or styles that seem to be showing up for the person? These assessments also look at so-called axis 1 issues that the person might be having. So like, is there a mood disorder, or is there another diagnosable disorder like PTSD or OCD or something like that that's comorbid? But it also assesses constructs that aren't included in diagnostic systems like the DSM, so like attachment style, for instance, and things like that. What I find is that a lot of times when people are referred for these assessments, typically by a romantic partner, it's not NPD, but rather it's like avoidant attachment stuff. So the person is having a hard time engaging in reciprocal, mutually satisfying, emotionally intimate relationships because they're scared. They're scared of them. They're deeply uncomfortable with the vulnerability that's involved, and that's different, than straight up like NPD, right? In NPD, that dynamic is often present, but it's also accompanied by self-esteem instability. So, there's often sectors of the personality that are sort of filled with split off, dissociated self-images and object images that are depleted, that are fragile, that are highly reactive, that can be filled with things like rage, like Kernberg is sort of saying, and stuff like that. And then there's also a kind of a compensatory part of the person that's filled with unrealistically grandiose, hyperinflated self-images and idealized object images. And that's the dichotomy, right? That sort of sets up pathological narcissism. As Aaron Pincus, who's a prominent researcher in pathological narcissism and NPD, stated at a conference that I attended late last year, in NPD, there's always the collapsed self-experience, right? But there also has to be a companion grandiose self-experience. And a lot of times when I do these personality assessments, that grandiose piece, it just isn't there, right? What you're seeing instead is somebody who has like a fearful, avoidant attachment style, and just has a hard time hanging with being close because of their own relational trauma history. Typically, there might be some CPTSD going on. There could be a lot of shame involved. That's not unusual as well. But there, without that kind of pathologically grandiose component that shows up, whether a lot or a little, then it doesn't qualify for NPD. So I hope that answers your question. That's, I would say, of all the kind of like conflated issues that a person might have that's mistaken for NPD, that's the main one in my experience, at least. So thank you. Okay, Jennifer Butler. Can a person with BPO, that means borderline personality organization, move into another level like neurotic? I say yes. Although I was reading the psychoanalytic subreddit the other day, and somebody was asking about, these personality organizations, and essentially your question. And so, and a member of that subreddit was like, well, I don't think Kernberg would say that a person can move between the personality organizations, that you're just kind of stuck with the one that you develop in early childhood. I disagree. And that has not been my experience. I don't know what Kernberg would say about this. I should probably look into it. But the personality organizations are, this is a developmental continuum, right? And as the person moves along this continuum, they are gradually developing increasingly sophisticated mental images of the self and of other people, right? Increasingly nuanced, increasingly integrated object relations. And, so the fundamental assumption that behind this model is that somebody progresses through these developmental sort of strata, right? All babies are psychotic, right? I mean, they're all psychotic. that probably doesn't sound very good, and somebody takes a soundbite off of that and like puts it online, I'm not going to look very good here, but it's true, because psychotic just means that reality testing isn't online, or it's not reliably online, and we know this to be true about young children, right? In the video that I made about psychotic organization and NPD, I provided several examples, one of them pertaining to my own life, of like the kinds of reality distortions that we all, with which we're all familiar when it comes to young children, right? The example that I talked about was, when I was 3 or maybe 4 years old. I think I was about 3 when this happened. My parents had just divorced, and I was in a new household with a new stepdad already. And I didn't know how to deal with it, apparently. And the way that my young psyche dealt with it is that I would see these phantoms, essentially. I called them shadows, but they would move across my room when I was trying to go to sleep at night. And it's not like I was, technically I was imagining them, but my experience was that they were there. I could see them with my waking eyes, right? These weren't dreams I was having. And I would call for my mom, and she would come into the room, and they would still be there when she was standing in the room. They would move through her. I have a very vivid memory of her standing in the room. I'm in bed. I'm like really upset. And she's like, there's nothing here. What are you talking about? And as she said that, I could see an elephant walking through her. Um, that's psychotic, that what the elephant wasn't really there. So that's what psychotic means, right? As we grow and as we develop, our ability to tolerate reality increases, and our perceptions become increasingly constrained by a reality-based experience of the world. Okay, but when we're really young, that's just not there. In order for that to develop, though, we have to kind of consolidate a stable enough sort of kernel of selfhood that resists distortion of reality. Just because I'm imagining it doesn't mean it's true, right? And ideally that happens, but it doesn't always happen. And of course, there are organic components too that play a part here. But when we're talking about personality organization, I guess the assumption then is that somebody could, in the absence of the kinds of early experiences that we all need to kind of put together that feeling of selfhood that's stable and coherent, somebody could kind of stay stuck, right, without those resources. And as a result, especially when they're very upset or distressed, their reality testing gets loose. And they can have delusions, or they can have hallucinations. They can believe things that don't make any sense to people who have a more reality-based perspective. What was I saying here? Right. So the assumption behind this model is that in the presence of the right kind of facilitative experiences, our psyches are able to develop in terms of ego functions, in terms of mentalizing capacities, in terms of the ability to hold multiple kind of internally inconsistent feeling states at the same time, right? So, these are things that, if you look back on your own life, perhaps you see yourself kind of gradually developing these capacities as you got older. Okay. So if that's the fundamental assumption behind it, I don't see any reason why somebody would stay stuck in the psychotic organization, or the borderline organization, or even the neurotic organization for that matter, because we are constantly growing and constantly developing across our lifespans. And so, yeah, maybe somebody's been stuck in that borderline range, right, where their ability to kind of discern the difference between self and other is fluid and not really consistent, where they're more often falling into a mode of organizing experience called the paranoid schizoid mode. In other words, that's a mode that is defined by the presence of paranoid anxiety, so the fear of loss of self or annihilation of self, because those ego functions aren't really stable. They're not strong. They're not robust. So they tend to fall apart, right? And when that happens, there's a loss of self that the person experiences. So that's the paranoid aspect. And then the schizoid aspect is that the person deals with that experience through the use of a specific form of defense called splitting. It's a very old, and by that I mean very immature or young defense. And it is identity distorting. Okay, so it's not just black and white thinking. These are divisions that form, that were always there. They just don't get kind of integrated. So these are divisions that are in the identity. And so that's paranoid schizoid. Okay. That mode of organizing experience really belongs to the borderline level of personality organization, although we all use it from time to time, regardless of how we're organized. And in the video I did on BPO, I talked about, getting like mugged or attacked in an alleyway, and how your mind will shift into the paranoid schizoid, right? That just right back to it. I don't care if you're the healthiest person on planet Earth. You will be in the paranoid schizoid mode of experiencing when your life is in danger like that. and then when the threat is passed, you regain the more sophisticated, nuanced mentalizing capacities that belong to higher levels of personality organization. Okay, so if a person can regress, then it makes sense that a person could also progress, right? And that's what my whole practice aims to help people do. That's what I try to do, is to facilitate that growth and development and maturation, essentially. And it consists of creating a safe enough, a consistent enough space where we can sort of hold and tolerate the paranoid anxiety when it comes up together. We can make meaning of it together, although often in the early stages it's just me making meaning of it, but gradually the other person can join me in the meaning making process. And by virtue of that kind of that dialectic, right, begin to integrate those disparate, split parts of self into something that's more whole and more cohesive. And we would call that then a neurotic personality experience. So yeah, I absolutely believe that a person can move. If I didn't, then I wouldn't do what I do. And I've also experienced it. I've seen it, a person moving from the BPO to the NPO, the borderline to the neurotic. Yeah, I'm not the only one who feels that way. I think I said in one of my videos, my most recent video, I think, my good friend Steven Johnson, who I always love to talk up, writes about it too, right? Steven Johnson, just kind of like, Steven Johnson isn't my friend, although I wish he was. Not because he like won't be my friend, but I'm just too chicken shit to like reach out. Anyway, this is his book, Characterological Transformation: The Hard Work Miracle. That's what he's writing about. So thanks for the question. Okay. Cassandra Watson says, good morning from Australia. Well, good morning. And thanks for joining me all the way from Australia. That's amazing. Okay. I love Yeshua 1992. What is your professional opinion on using antidepressants during the treatment of NPD? Well, I'm not a psychiatrist, so that's outside my scope of practice. I don't tend to question it. Honestly, I think that psychopharmaceuticals have their place. There are lots of people who experience a significant increase in their quality of life when, with the aid of appropriately prescribed psychopharmaceuticals like antidepressant medication. Antidepressants won't treat the NPD, right? That's an important distinction to make. Antidepressants will help with some of the sort of accompanying issues that can happen in NPD, like mood disorders. They can help alleviate things like severe anxiety or bring it down a bit. They can help. They can have an impact on the kind of depressive or anxious ruminations that can happen sometimes as well, and stuff like that. Things like social anxiety. I think a lot of people who have NPD, but are more vulnerably present in a more vulnerable way. They oftentimes will be misdiagnosed with things like it used to be called dysphoria. Now it's called persistent depressive disorder. I've seen that happen a number of times. And they just think that they think that they're chronically depressed. And they are, right? But not because of some like chemical imbalance per se, but because of an underlying personality disturbance. So, something like Prozac or whatever, it's not going to change how, like the fundamental issues with self-image or identity or self-esteem. But it might help to turn the temperature down a little bit on some of the mood or anxiety issues that often go along with that. And I think that can be really helpful for folks under the right circumstances. Thanks for the question. Ralph J says, how often will I do live videos? Well, that's a good question, Ralph. Thank you so much for asking it. Okay, so I remember the last time I did this, I said that my aspirational goal was to do them once a month. And that was last July, I think. So obviously I'm not living up to that goal. What happens is that I get anxious about this because I just, like cause right now there's 92 people watching. And all of you feel, or I guess hope, that I'll have something helpful to say. And that feels like a lot of pressure. So I think I tend to avoid this and until I get into it, and then I have a good time. So that's my own psychology on display there. The other piece of it is that during the year, like the academic year, I'm just like super duper busy a lot of the time with a practice, and then I'm also a professor in this ID program. And I've got classes to teach and papers to grade, and it's just like just life really starts to happen during the fall and especially the spring. And I have such a hard time finding like an hour and a half to like do this. But if I'm being super honest, if I'm just like being really candid, it's mostly that it makes me nervous. And so I can, it just gets that much easier to just be like, well, I don't have the time, I could probably find the time, and I probably should find the time. So thank you for asking, though. And I would like to be able to do these on a monthly basis. I'm not going to commit to it, but I should do them more often than once a year. I think that's for sure. And I'm so glad that you're here watching now. So thanks. Okay. All right. If possible, could you tell me more about how the self can change in relationship with another person? I remember you said that there is no self without another. Yeah. Well, I guess I would say that I don't think the self can change outside of its relational contexts. Yeah. So there is no like, okay, what is self, right? It's a loose construct. It's ever shifting. And I think we are increasingly coming to understand that self-experience is comprised not of like a monolithic, static, thing, right? It's but rather it is highly variable. It's context dependent. It can expand to include the whole of a person's experience, right? I think Freud called those oceanic experiences. These are the kinds of experiences that people have when they're having like a profound spiritual, epiphantic kind of, experience. People can reach this state of subjective experience, when they're like meditating or they're engaged in contemplative prayer of some kind. People can also have this kind of an experience, when they're at like Coachella and like their favorite band is playing and the whole audience is moving in rhythm to the music, right? And also, I think this is the sort of experience that is often facilitated by the use of psychedelic drugs as well. right? So the boundaries of self just dissolve, and all of it sort of becomes an experience of self, right? And the distinctions between inside and outside go away. And that, to a lot of people, they find that to be a blissful kind of experience. Um, but self-experience can also collapse, and it can shrink down to become identical with a single thought or a single feeling or a single experience. And you often see that kind of diminution of self-experience, like when a person, let's say they're in love, right? Or maybe something happens that's just like profoundly humiliating, and they kind of can't get past it, you know. So self experience is variable and it runs the gamut. So that's one aspect of self experience that we're kind of increasingly recognizing. Another aspect of it is that all of these different parts of self, they're all kind of relationally bound. So there's like a part of me that has to do with, you know, a specific kind of part of my mom. There's a part of me that has to do with a specific part of my dad, right? There's a part of me that has to do with first grade. There's a part of me that has to do with college. There's a part of me that has to do with my spouse or my, you know, so like there are all of these different kind of complexes, I guess, or constellations of self experience, and there's always an other there of some kind, right? And that makes sense because you know, the self. What is the self if it's not in relation to something that is not self, right? Even if it's self in relation to self, well, then one part is experienced as self, and one part is sort of like contextually experienced as other in that frame. And so, you know, and these ideas they go pretty far back. Donald Winnicott, back in the '60s, I think it was, man, it was maybe even earlier than that, was writing about this idea that there is no child without a mother and there is no mother without a child. These two roles are mutually defining, right? They co-construct each other. And this just is what it is to be a subject. You know, this is what it is to be a self, to my mind. Sorry, let me get back to your question. So how can the self change in relationship with another person? Okay. Well, I'm going to talk about like therapy and the experience of change in therapy. A person comes into treatment, and they carry inside of them a certain set of assumptions about how that relationship is going to go, right? Not just how the relationship is going to go, but what the relationship is, what it's made out of, right? They have an assumption about, let's say, me as the therapist before they even meet me, right? Maybe it's based on my YouTube stuff, but even if I didn't have any public presence at all, they would just, you know, they see my name on a piece of paper, and there's a whole bouquet of assumptions that come up around that, right? And all of those assumptions are in some way derived from the various self experiences that exist within them, and the relationships that the relational context that those experiences are bound up in. So, you know, I'm expected to be some kind of a healing figure, right? Okay. Well, your healing figure that you imagine is going to be different than the healing figure that I imagine, right? I mean, you know, even the idea of healing is highly individual and specific to each person, right? And it's defined by, it's made of their experiences of healing or of being healed, right? You know, I just did an assessment with somebody who spent a majority of their childhood in hospitals because of chronic illness, and let me tell you, those weren't positive experiences. You know, Those were experiences of being separated, being alone, being terrified, being poked and prodded, and all for like your own good, so to speak. But what is the experience to this person of being helped, of being healed, right? It's one of intolerable vulnerability, of naked exposure to cold, penetrating, intrusive medical procedures, and the absence of reassuring attachment figures. Okay, so that's what a helping figure is, maybe to that person. So the person comes to treatment, and they've got this subjective, highly individual universe inside of them, and I've got mine, right? And now we sort of meet, and they are constructing me based on their psychology, and I'm constructing them based on my psychology. And this is called intersubjectivity. This is a fairly recent branch of psychoanalytic theory and practice. We are mutually co-constructing each other. That's what happens in any relationship. The difference, though, in a treatment relationship is I am, or the therapist is, more often than not, aware of this mutual co-construction as it's happening, mindful of how the other person seems to be experiencing me in this moment, curious about how that experience is constructed inside of them, and the limitations that it seems to place on them, right? To use this patient that I just described as an example, that patient is phobic of emotional intimacy, of closeness, of vulnerability. Geez, I couldn't imagine why, right? I mean, if your childhood is made up of really negative and painful experiences of vulnerability at the hands of people who are supposed to be there to help you, well, it makes a lot of sense, right? But those expectations are influencing or coloring how this individual experiences me in the role of a helping professional, right? So as a result, it's also kind of informing how this person expects me to act, and therefore how they perceive my actions, right? These are a set of prior assumptions that they're bringing into the situation with them, and part of my job, were I to treat this person, would be to try to gradually, over time, sort of mentalize, think about what seems to be going on there, to think about how it intersects with my own relationally bound experience of self and other, and then to gradually behave in ways that, rather than kind of collapse that process or just react to it, open up a space where we can be more tolerant of the trauma that informs it, the individual, like the separateness that precedes it, right? Like the fact that he's over there having his own dream, and I'm over here having my own dream, and somewhere in the middle there's presumably like an objective reality, but it's hard, right? It's hard to get through the patient that I'm constructing and the therapist that they're constructing, right? I've wandered off topic again. But I guess what I'm trying to say here is that by the therapist being gradually like learning gradually over time who the patient expects the therapist to be and how that resonates with the patient's early experiences, let's say, you can start to get a sense, okay, well, the parts of the patient that are sort of relationally bound to hurting caregivers are here in the room, but now they're relationally bound with me. And that actually is what makes treatment possible, right? That's what makes it possible for treatment to not just be a series of like mind-blowing insights or whatever, and to actually work to change the deep parts of a person's psychology, and by extension, I guess, the parts of themselves, right? Because that those parts of self that are defined in comparison to hurting caregivers over time would gradually become to be redefined in relation to hopefully an actually helpful, curious, warm, consistent, present caregiver in the form of the therapist. And that's not that is not a process that a person can do in isolation, right? That individual could sit alone in a room for years and years and years on end, trying to like work it out, right? But it would never actually happen because it needs to be worked out in a relational context with an actual other. And that's the whole like that's what the whole relational model of contemporary psychoanalytic theory and practice hinges on. That is the linchpin, right? That none of us are built in isolation. All of us consist of an internalized universe of relational constellations, and every thought you have about yourself is relationally bound and contextualized. And really, I think what it actually means, again, there's a kind of like central paradox, because it means that all of us are kind of fundamentally alone in that respect, right? There is no, like, if you're sitting in front of me, I'm not necessarily perceiving you, accurately. I'm perceiving like a series of projections, that are based on my own experience. But it also, I think, at the same time means that none of us are actually alone. None of us are actually isolated, because all of us are built out of internalized relational experiences. So anyway, that's all I have to say about that. I hope it was helpful, and I hope I didn't wander too far off course. And thank you so much for the question. All right. Owen. Hi, Dr. Ettensohn. Is the latest consensus that NPD is a complex trauma response? Must there always be trauma for NPD to develop? Thank you. I don't know if it's a consensus. I just made a video a few weeks ago addressing the kind of increasingly made claim that NPD is almost entirely genetic, and it's a heritable disorder. I think there's a lot of confusion out there about this. I don't think that the matter is settled. I take that back. To my mind, the matter is absolutely settled, that NPD is a complex trauma response. But it has within it a certain component of that is heritable, that is genetically predisposed, right? And this is true. We know this to be true about most forms of mental illness. That, it's rare, right? It's like, I can't think of a form of mental illness, although I'm sure there are some that are just like, it's just genetic determinism, right? Like if you got the gene, you got the disorder, and it's a mental disorder, right? I think even in things that are just like kind of indisputably, where there's an indisputably a neuro anatomical substrate, like schizophrenia, or something, where you're just like, look, like you look at the brain scan, you're like, see, schizophrenia, um, even then, we know that there's a sort of a diathesis stress component where it's like, okay, this person maybe has the genes, but you need the environmental trigger. You need the right kind of experiential, context for the disorder to emerge and become full blown. We see that like in the video that I made about this, even something like Alzheimer's disease, where you're like, hey, look, here's the ApoE4 gene, just boom, like this is it, right? People who have this gene, they are much more likely to develop Alzheimer's disease. Even then, it's like 40 to 50% genetic, right? It also comes down to things like diet and stress and like exercise and stuff like that, right? So it's not guaranteed that you're going to get Alzheimer's, even if you have like the identified gene, right? And for something like NPD, there is no identified gene. The best that we have are twin studies and a series of brain imaging studies. And the brain imaging studies don't tell us anything about origins. They just tell us, hey, look, when somebody has this syndrome, it's accompanied by these alterations in neuroanatomy. Okay, right? Well, how do we know those aren't caused environmentally, right? How do we know that somebody who's raised in a narcissogenic environment, right, where they're subject to chronic, maybe subtle forms of emotional invalidation, neglect, hypercriticality, and pressure, right, to be a certain way, to how do we know that a person's brain developing in that environment doesn't just look like this picture, right? We don't know that. There's no way to know that. The only way to know that would be if we had just really robust longitudinal studies where they're imaging the brain, across the lifespan and that sort of thing. And nothing like that exists. There's no isolated gene or series of genes that are highly correlated with NPD. And for that matter, that even the definition of NPD is highly contentious. People don't agree. Experts don't agree on what NPD actually is. And that I've made a number of videos about that as well, including the first video that I made on my channel, which talks about the sad state of NPD research up until 10 years ago or so. So, I disagree with what I'm pointing up here, because there's my DSM-5. I disagree with what the DSM-5 and the DSM-5 text revision have to say about NPD. I don't think they got it right. I don't think they've ever gotten it right. And there's plenty of peer-reviewed clinical literature that's in agreement on that matter. So the jury's out. Here's what I'll say about it. I see NPD as a highly complex series of adaptations, and I have a hard time believing that any of those are just purely genetic. Although I think there's always some genetic basis, some genetic vulnerability. Maybe in the form of temperament, maybe in the form of emotional reactivity, maybe in the form of innate empathic capacities. But again, you take somebody who's got all, let's say there are genes, right? You take somebody who has all the NPD genes, whatever they might be, and you put them in just an absolutely idyllic early care environment where they are loved and supported and encouraged to sort of connect all the different parts of themselves together and communicate honestly and authentically, and they're afforded the space to feel and to be expressive of those feelings. I don't think you're going to end up with somebody who's got NPD. I don't. I think there needs to be a series of traumas, relational traumas, like I was saying to the previous commenter. Parts of the self, they don't develop right. And it's because of the relational context in that early care environment. And it turns into lifelong deficits and disabilities. And then you need to have a sustained corrective, for lack of a better word, relational context to sort of grow and develop out of that that pathology. So, yeah. My take on it is absolutely a complex trauma response. I'm working on an article that I hope to submit for publication that even takes it a step further than that. I don't want to say too much about it because just in case somebody's like watching and they're like, aha, I'm going to write the article first. But my way of conceptualizing NPD is evolving, partly by virtue of all of this work that I do on it. I increasingly see it as trauma. So thank you for the question. The Sage of Syndra. I wanted to thank you for your video series. It helps me to understand I had NPD symptoms and behaviors and has put me on a path of real healing. Well, thank you. I'm really happy to hear that. And welcome to the channel. And thank you so much for sharing the impact it's had on you. It's why I do it. And it's just deeply meaningful to me to hear from folks who find this helpful. Okay. What to do if a person diagnosed with NPD is a close family member and he always harms me whenever I'm around him? It gets difficult for me to have empathy for him, though I want to and wish well. Yeah, well, empathy and boundaries are not mutually exclusive, right? You can have empathy for somebody and never go around them, right? I think if somebody's hurting you or harming you whenever you're around them, then my advice to you would be to take a serious and long look at whether or not you need to be around this person. You can care for them from afar, if that makes any sense. I think when we allow somebody to hurt us, that's not having empathy for them. It's bad for you and it's bad for them to allow somebody to harm you. It's bad for everyone. So I wish you well. And it's okay to take care of yourself. It's okay to have boundaries. It's okay to say no. It's okay to say, like, get the fuck out of here, right? It's okay to say never talk to me again. All of that's okay. It's just because you can empathize with a person's mental illness, let's say, or disordered behavior or circumstances, it doesn't mean that you can't take appropriate and necessary action to protect yourself. Just a really important point. I don't think I can say it enough or clearly enough, and I also don't think I say it enough or clearly enough. But yeah, protect yourself. Okay. Narcissist Hex. Hi, doctor. I'm a self-aware narcissist and unable to afford therapy. Well, according to the internet, then you don't exist. No, just kidding. Obviously, you exist. Obviously, self-aware narcissists exist. I started my YouTube channel, and do you think this might help instead of therapy? It keeps me busy, at least. Yeah, I think it can. I think it can absolutely help. There are several channels out there, of which I'm aware, that are run by folks who are either diagnosed with NPD or they're self-aware of their narcissistic traits. And I think they do a lot of good, not just for the person, but for the community. I think that this is a disorder that has been sort of like so heavily imbued with stigma and bullshit for so long. I hear about it on a daily basis, just about. I get emails from people all over the world at this point on a regular basis, letting me know just how alone they feel, just how alien they feel, just how hurtful it's been to try to get any information about these issues that isn't like just about how they're a monster and a demon, whatever else. So I thank you for being out there and for trying to spread information that is true. I'm assuming to your experience. I haven't watched your channel. I'll say this. I think whenever somebody has an adversity, right, has a disability, let's say, and they use that experience of adversity or disability or pain or suffering to try to help somebody else, I can't think of a better use of your resources. I think that is, there are probably aspects of pathological narcissism that only you can speak to, because of the intersection of your individual experience and your individual voice. And I think that as long as you're trying to help, go for it. And could it help you? Yeah, I think it can. I think the way that we learn something best is by teaching it. Right? I know that the concepts that I teach in my classes, and even this channel for that matter, I learned so much just by making the videos that I make and teaching the concepts that I teach. Finding a way to package them and say them in a way that will be relatable to other people helps me to make important connections inside myself. And I think that's true for any topic. Go for it. Yeah, good for you. And thanks for being here and sharing. All right. Some influencers said that people with NPD intentionally abuse their partners because they're able to control their behavior in public and only act out in private. What's your opinion on this? Yeah, yes, and no, and I don't know. The problem here is I don't know. How do I want to say this? I've reached the point where when I see a video that's supposedly about narcissism, I just don't make any assumptions that I know what this person is actually talking about. Like, are they talking about narcissism as I understand it? Or are they talking about like the kind of like popular um like, you know, uh heavily stigmatized construct that shows up in all of the forums and all of the kind of like big name, YouTube channels that are supposedly about narcissism? Are they talking about their like, you know, father or their husband, or are they talking about, I don't know what they're talking about. And I think oftentimes they don't either. And that's, it is such like a Tower of Babel, the popular discourse around these issues. I so okay. That being said, um, yes, there is something that happens where a person who has pathological narcissism or NPD can have really disparate, like internally inconsistent presentations depending on context, right? So, it's like somebody with NPD can be really sensitive to shame and humiliation and like looking bad, right? Because their sense of self, like falls apart if they feel like they're not like giving good face. You know what I mean? If they feel like people aren't admiring them or looking up to them somehow. So I think somebody who's organized like that can be really good at appearing balanced, stable, reasonable, whatever, like just a solid guy, to the public. Okay, when they're out at the restaurant, when they're at the meeting, when they're in client facing capacities, when they're at the like barbecue, like because the individual really is trying to, in those moments, get a kind of self-object experience, a kind of feedback that helps them to organize their internal sense of self. Okay. Um, so they put a lot of effort into it, and it can be really convincing to everyone, themselves included, right? Of course, it has to be convincing to the individual themselves, otherwise it's not effective. So, versus what happens in close, intimate, private relationships, where there's an awful lot of projection, let's say, where there's an awful lot of boundary blurring or boundary confusion, where there may be like months or years or decades of history, um, that can pull or be an opportunity for a different side of the person to show up, a more dysregulated side, the part of them that like, okay, so oftentimes in romantic relationships, we tend to project parts of ourselves on the other person. Often in the early stages of the relationship, we're projecting all kinds of idealized stuff onto the other person. And you don't have to be a narcissist to do this. This is just what people do, right? Oh, he's the one, or she's the one, or right. I mean, we romanticize the other person. And what's that romanticizing made up out of? Our own projected fantasies, right? But then over time, that experience tends to give way to a deeper kind of intimacy, where we've seen and experienced all the different parts of the person, and so so we're not idealizing them in the same way, but hopefully like a different kind of love has come to take its place, right? A more like a whole object love, where you're like, I love this person, warts and all, so to speak. But somebody who's fragmented inside, who's a person in pieces because they are more in that borderline personality organization space, they're not able to hold the good with the bad, And so when the bad starts to show up in the relationship, it tends to color like the entirety of their experiences, especially in certain situations. So like, when the person is really frustrated or really distressed or really stressed out or something like that, resulting in a kind of, like that, like a devaluing, mistreating the other person, right? And that has to do with the internal personality dynamics of somebody at the borderline level. And in NPD specifically, it often involves projected shame, um, uh, like feelings of rage or anger or resentment that have to do with feeling compromised or criticized or underappreciated or humiliated, stuff like that. And so that's the kind of stuff that will only show up usually in the context of an emotionally intimate relationship, as or like a waiter at the restaurant who fucked up the order, but it's not the kind of, it's not something that somebody is typically going to be like expressing on like a big stage, who has NPD for like everyone to see, unless they're just really disorganized and really pathological. So this duplicity is not usually intentional. It's not like a studied thing, typically, although sometimes it can be. But I would say, generally speaking, it has more to do with the stakes that the narcissistic individual feels in public, and what they're attempting, again, unconsciously attempting to do in that venue, versus the parts of them that are sort of allowed to become more disorganized and dysregulated in the context of a familiar, close, safe, so to speak, relationship, that heavily involves like blurred interpersonal boundaries and facilitates like projection and stuff. So I hope that answers the question. I guess what I'm saying is, yes, I think that happens. I don't think it happens for the reasons that most people who talk about this say it happens. All right. There are so many terms: vulnerable, grandiose. There are also levels. Tell in detail about thick-skinned and thin-skinned. Is it true that some are treatable and some only offer supportive therapy? Thanks. Yeah, well, I think for the most part, you can take all that stuff and just throw it right in the garbage. And by that, I mean all these ideas about, oh, well, he's a covert narcissist, or he's an overt narcissist, or he's a grandiose narcissist, or he's a vulnerable narcissist, or he's a thin or a thick-skinned narcissist, or whatever it is. These aren't, there is no evidence, especially recently, since this kind of this renaissance of investigation and theory about narcissism has happened in the last 15 years or so. All of those former categories have largely been abandoned. Okay, the idea of a vulnerable narcissist or a grandiose narcissist. Let's just start there. And by the way, I talk about this in my book, and I'm using some of the old ways of conceptualizing in my book because I wrote it 10 years ago. I write about vulnerable types or grandiose types, and I know I don't believe in those anymore. So the current understanding is that all forms of pathological narcissism involve both vulnerable and grandiose self-experience. The person moves in and out of these different self states. Some are more grandiose and narcissistically defended. Some are more vulnerable and depressive and collapsed. Different personality configurations, these are highly individual, may have may experience more of the kind of vulnerable self-experience, and some may be more grandiose, but all of them have both vulnerable and grandiose aspects. That is what pathological narcissism is, right? It's a sensitivity, an instability in self-esteem that is then compensated for using grandiose self-inflation, idealization, that sort of stuff, right? Okay, so to have narcissism, you must have both. Now, how often the sort of vulnerable piece is overt or readily identifiable and conscious, that's a different question. And like I said, that has to do with the individual. There isn't like a type, okay? So I want to kind of make that very clear, that every person who has NPD is a vulnerable narcissist and a grandiose narcissist. And the ways that those kind of like interplay and come together inside the person, highly individual, highly complicated, highly context and relationally dependent. Okay. The idea of thick-skinned and thin-skinned, those are outdated terminologies that have to do with the vulnerable and grandiose experiences. Like like thick-skinned means grandiose, used to be called an oblivious narcissist or a phallic narcissist, right? I mean, there's just all these different terminologies for it. I'm trying to remember who the researchers were that did, I think it was Kane and Pincus, did like a really good lit review about 15 years ago, where they went through all the literature and they just like compiled this spreadsheet essentially of all the different terminologies that have been used. And they all kind of show this basic dichotomy, this basic valence between vulnerability and grandiosity. Okay, so when you say thick-skinned and thin-skinned, what you're really saying is grandiose and vulnerable, right? So, okay, that being said, I think it's true that some folks who present for treatment, are more amenable to the process, right? By virtue of kind of how they're put together. I think for the most part, in my experience, somebody who is more often overtly vulnerable, there is a better treatment prognosis. And that's because the grandiose defenses in narcissism are defenses against dependency, right? They're defenses against vulnerability. In other words, like, how does therapy work? Well, you have to be vulnerable, you have to be open, right? You have to allow yourself, at least eventually, to be seen and understood in light of your deficits, in light of your vulnerabilities, right? In light of your pain. And grandiose, compensatory, grandiose defenses in narcissism are all about shutting that process down. So somebody who's more often occupying that grandiose space, well, they're more defended against like the purpose of therapy, right? And so I think somebody who's kind of more grandiose will seek treatment less frequently. They will have a higher tendency to leave therapy prematurely, and they'll be more guarded in therapy. And I've seen it. That being said, I have folks in my practice who are like really grandiose, and I think, but these are people at the same time who sought out treatment. usually because there was a collapse of some kind and somebody said, you're a narcissist. And then they looked up what narcissism, and then my face showed up. And so they reached out to me. Sometimes it's like them reaching out to me is because I'm like, they perceive me to be the expert, and they only want the best, right? Okay. So then they come and we start the work where they are. Where will it lead? I don't know. I can't say. I can't see the future. But as long as I feel that there is a part of them that is engaged in good faith, I'm willing to put in the work with them. So, okay, there you go. Hope that helped. After narcissistic collapse, I feel like a 4-year-old boy who never learned how to live relationally, while my false self, neurotic level, lived a whole life of desire and adventures. Advice. Okay, so what Ziv is describing here is actually a pretty sophisticated way of articulating this. Okay, so oftentimes folks who have NPD, they're organized at the borderline level of personality, right? Okay, so they have all those issues, splitting and boundary confusion and stuff like that goes along with that. But there is a part of the personality that is internally coherently organized, and we call that a false self. And the false self typically has a neurotic extension. So because it's so kind of internally consistent, right? When a person is in that false self experience, they're like, this is who I am. This is what I want. And this is what I'm going to do, right? So that kind of like internally organized self experience really kind of like lives in a neurotic range. Okay. But the false self is dissociatively isolated from the rest of the personality, right? So one way that I expressed this in a previous video is the false self is an island of cohesive identity that sits in a sea of identity diffusion. And identity diffusion is what we find at the borderline level, where it's like the different parts of self kind of don't fit together very well, because they haven't had those relational facilitative experiences to sort of say, oh, this is how these fit together, right? So what Ziv is saying here, I think, is that when he experiences collapse, he's no longer on that false self island where everything kind of makes sense. And instead, he's swimming in the sea of identity diffusion. And as a result, he feels very young and very vulnerable and very confused. And I think that makes a lot of sense. I would say that is... Okay, so the temptation here is to say, well, that's a more authentic experience, but it's not true entirely. The false self is authentic in its own way. It's authentically organized around external contingencies, right? Okay, I know who I am so long as I know what you want me to be, right? So there is a way that separates a person from their internal, authentic, ever-changing, emotional landscape, right? But the false self is still the authentic effort of the person to be someone who's worthy of love, who's worthy of being a self, right? So it's not true to say that one is authentic and one is not authentic. One is closer to the kind of intrinsic internal state of the individual, right? So when you're kicked off of that false self island and you're in the water, you don't know where, you can't get your bearings, and you feel lost and overwhelmed and confused. What you're experiencing right there, right then, that That's old stuff, right? That's how you used to feel all the time. I was watching, I think I caught like part of an interview that Bill Burr was giving. He was talking about taking psychedelic drugs and how they changed him. And what he was saying was he took some shrooms and he just felt awful inside, right? Like he was forever alone, unlovable, like fundamentally broken and lost. And he was like, oh shit, I'm having a bad trip. But then what he realized in the midst of that bad trip, so to speak, is no, this is just how he always used to feel when he was a kid. And he'd forgotten about it. He'd covered it over with all kinds of like, adaptations and defenses and whatever else. You know what I mean? All this performative stuff. And the drugs took it away. And now he was remembering, for perhaps the first time, what it actually felt like before all of those adaptations came into play. And I think that's what you're describing here. I think it's why you feel like you're 4. I would actually say it's even younger than that. But this is taking you. It takes you back to a part of yourself that has been left out. I would say, let it back in. It's going to hurt. It's going to suck. That's why you created this whole false self to begin with, right? But it's real and it's true. It's true in a different way than the false self experience. And it'll make you whole if you let it. Right? Okay. I'm at 3:30 here. I was only going to go to 3:30. I'm going to go a little bit longer just because I'm feeling it. So if you can hang, great. If not, I totally understand. But I'm going to keep going a little bit longer here. Okay. Okay, Christian Smith. Are you going to publish a book for us narcissists? I know the book you have now is useful for us, but just curious if we'll get our own. Thanks for being such an amazing ambassador for us. Yeah, that's the book I'm scared to write. But why am I scared? Because I want to get it right. Yeah, I want to get it right, and I. Yeah. So, but yes, that's the book I want to write. That's the book if I write that book and I get it right, then I can feel like I did what I'm here to do. So anyway, yeah. Thanks for asking. And yeah. Okay. Mapstat. What would be the biological mechanism of healing? If cluster B disorders really are failure of ego formation, how does one form an ego later in life, past the developmental stage? Well, you do and you don't. You know, I think I talk about this kind of paradox in I think it's my most recent video about crossing over into the neurotic level of experience. You can't go back and undo what was done, and you can't be uninjured. You know, like if you're injured, you're injured. If you're hurt, you're hurt. You can't undo the past, right? But that doesn't mean that you can't develop a more integrative mature and whole self image around what happened. So I guess what I'm saying is you can come to a different understanding of the hurt or the injury or the pain or the abuse, whatever it was that sort of caused this, right? Is a great analogy that comes to mind, and it's about grief, right? So, there's this idea that when you lose somebody and you're grieving, right? The grief never goes away. You don't ever feel better about the person, the loss of the person. But what happens over time is that you get bigger, right? The space inside gets bigger. Okay, so you grow around the loss such that it doesn't take up as much space. And I think that's a good analogy for the kind of growth and development that can happen, like in therapy, for instance, right? Is that it's not that that little kid ever isn't hurt inside. That's a part of your story. That's a part of you. You'd have to be a different person for that not to be true. It's true. It's what happened. But you can grow around it. There can be more space inside to hold it, so that the pain doesn't have to take up so much of your psychology. And how does that happen? Well, it happens gradually, through self-exploration and through the kind of relational experiences that can happen in a good therapy, through the new connections that you start to make, through the shifts in perspective and the development of self-compassion over time, through the new narrative that you can start to weave about who you are and what happened and what it means, so that there's less reacting and there's more reflecting. And I think that is what psychological maturation, that is psychological maturation, right? That's what it is to be at the neurotic or the healthy level, let's say, especially the healthy level, where things are flexible, where you can think about all the different parts of your experience, and not have to be reactive to them or exclude them or, distort reality or your self-image or your image of somebody else because of them, and so that's I don't know, I couldn't speak to the biological mechanism there, but it's a slow growth over time of reflective and mentalizing capacities. And we know that it's possible to develop these capacities. We, like studies of folks who sit every day in meditation, for instance. Brain imaging studies show that they have an increase in gray matter, right? And the parts of their brain that have to do with empathy increase. So it's like the brain is exquisitely plastic. It can change and grow. You can't go back in time and undo something that was done, but you can grow around it, right? You can redefine what it means for you, so that you don't have to be pushed around by it in quite the same way. Yeah. So I hope that helps. Let's see. Allie B, what's my view on somatic healing? I've been going to trauma-informed acupuncture alongside my talk therapy because trauma is stored in the nervous system. Yeah. Good. if it helps, do it. Um, absolutely. Yeah. There are like old traumas that are laid down somatically. Absolutely. 100%. And maybe you access those through healing touch, or maybe you access those through self-care, or maybe you access those through acupuncture. Do I think that like the needles are, I mean, I don't know, maybe they are, is like the trauma stored like right there, or right there, maybe, but being in your body in an intentional way that contains like that has within it like a healing intention, yeah, I absolutely do that. And I'd be interested to hear at some point, if you find it helpful. I mean, you must if you do it, but um, how you find it helpful, I'd be interested to hear. Okay. Well, this is sad here. These kinds of situations are hard. How can I protect my toddler from narcissistic father? Court didn't help, unfortunately, so not able to give the consequences needed for him to become aware. Okay. Well, you can't. I mean, it sounds like you've exhausted your legal options, and you're going to have to co-parent with this person. And I don't know anything about them. You're saying they're narcissistic. I don't know what that means exactly. Like I said before, I think this term is thrown around so much it could mean all kinds of different things depending on the person. But I think whatever the case, something that makes a huge difference for kids growing up is if they have one person, just one person in their life who is consistently making an effort to see them accurately, to talk to them about their feelings, and providing a model of what it is to be emotionally connected and present and safe. I think if they just have just one person, it can make a huge difference. Um, and you can be that person, and your kid will be better off for it. Um, so thank you for the question. Yeah, Dr. Ruth agrees with me. Thank you for agreeing. Yeah. I'm glad to hear that resonates with your experience. And welcome. Thank you for being here. I didn't know you were here. She says in her practice, she's seen a lot of people whose partners believe them to be narcissistic, but on assessment, strongly avoidant attachment. Yes, it is often mistaken for narcissism, uh, quite frequently. And without that grandiose component, without the intrinsic sort of self-esteem instability, you're not dealing with narcissism. So thank you for being here, Dr. Ruth. And hey, by the way, we had a plan at some point to do like a collaboration. And then you got sick, and then I got sick, and then it just kind of fell off the radar. So let's I'd be interested in picking that back up. Okay. Oh, interesting. Some of these are repeated. Some of these comments, I'm not sure what's going on. So yeah. Okay. Kohat's. Yeah. Okay. Uh-oh. It's not letting me click on things now. Hide current comment. Okay. Hey, I don't know how long I was gone just now. It apparently stopped, like I lost my internet connection, but I'm back. Okay. And I lost my place because it kicked me out. Okay. So somebody says, Bettis C says, I think if NPD was purely genetic, we'd be seeing a lot more narcissists. Yeah, maybe. Yeah, narcissism is fairly rare in the general population. In the clinical population, it's somewhere between 5 and 10%. In the general population, so it's around, well, the most recent figure I saw, and this was from a 2014 survey of empirical data about narcissism, it was still between 0 and 1% diagnosable NPD. So yeah, it's much more rare than the internet would have you believe. Okay. So it looks like some of these comments are folks talking among themselves, and I think that's great. Feeling well in a relationship. Okay. Ali B, do I have advice for healing while in a relationship? Since I have started therapy for my NPD, I've become more symptomatic. Yeah, that happens. I understand this is normal, but it's affecting my relationship. Okay. Yeah, just be open, as open as you can be, and patient with yourself. A lot of the stuff that kind of drives the more problematic behaviors in NPD has to do with like pressure, right? Internal pressure to be a certain way, to feel a certain way, to show up a certain way, to be regarded a certain way. All that pressure makes it really hard to think, you know. And the treatment for NPD and pathological narcissism is to gradually increase the amount of space inside, the ability to hold and contain and tolerate self states that you don't like, that it seems other people won't like, parts of you that feel or that you've been sort of taught, are unacceptable, right? And so, you know, um, the thing to do, I think, both inside yourself and in your relationship, is just to try to be as open as you can be. I'm having a really hard time with this right now, or I'm feeling just super insecure right now. Couldn't tell you why, but I'm just feeling, that's how I'm feeling. Or I'm feeling vulnerable and unsafe, or I'm feeling anxious. Whatever it is that you're feeling. Even if it's, I'm just feeling super judgy about you right now, you know? But if you say something like that, try to contextualize it with, okay, in my treatment, I'm becoming more aware of my own internal reactivity to shame or embarrassment, or things about other people that I things about myself that I don't like, or things about other people I don't like. So right now I'm being judgy, but it doesn't mean that I don't like you, or it doesn't mean I don't love you. But I'm just, I'm working on tolerating that experience and not being reactive to it. So, you know, what else are you going to do, right? You can't not feel the way you feel. The best thing you can do is to try to create space for it, to try to cope with it in a way that's not destructive to yourself or to somebody else, and to be honest and communicative about it. So thanks for the question. Okay, Man Miller, hello. What is the research around comorbid NPD, BPD, and how do you think they co-occur? Yeah. Well, I don't know research in terms of like figures, like in terms of epidemiological figures right now. But I think they often co-occur, right? So I think this is sort of like the old saying that depression and anxiety are like kissing cousins. It's kind of a gross saying, but it's what I don't even know. Is that a saying? I don't know. It's what I heard in graduate school. Okay, so anyway, that these are like that they're basically what it's saying is they're related, right? And I think the same thing goes for NPD and BPD. I think they are close in terms of they're similar in terms of their organization. It's just a matter of kind of like where the kind of like core, like the primary core conflict sort of lives. Is it about is it sort of more along the lines of attachment anxiety, or is it kind of more along the lines of attachment avoidance? But as far as like underlying personality organization, yeah, I think both of them kind of tend to sit in the borderline personality organization range. Both of them involve unstable self and object images. Both of them involve splitting. Both of them have a tendency to externalize distress, so to hold other people responsible for how you're feeling on the inside. It's just BPD tends to be more. It tends to be messier. There tends to be more disorganized internal experience, whereas NPD has that false self island, right? Of internal coherent self experience, and that's a defensive adaptation that is kind of particular to NPD. BPD tends not to have that. And so it tends to be more outwardly expressive of distress, and there tends to be more of a the person tends to resort more to things like acting out, and like self-harm and stuff like that in BPD, whereas NPD there's more of a tendency to devalue and inflate self-experience rather than collapse into more disorganized, dysregulated internal experience, like with BPD. Jesse Holmes, Kernberg thinks NPD and BPD is separate than CPTSD. Well, good for Kernberg. The longer I do this, the less. So it used to be, especially when I was like first starting out and I was writing my dissertation and all that stuff, where I would be like, Kernberg, like he knows, right? And the more mature I get in my career and the more of my own ideas, I kind of evolve in my practice and my work, the less idealizing of somebody like Kernberg I am, and the more I'm kind of like, well, does anybody know? Does anybody really know? I don't think so. Like, I think we're all trying to sort of take our best guess. And Kernberg's, theory, it's internally consistent. It's coherent. Some really good work has come out of it, especially in the form of transference-focused psychotherapy. And I use his concepts as well. But I don't know. I see increasingly, I see personality disorder as a trauma-based syndrome, as a form of CPTSD. And honestly, I think that's where the field is heading as well. So Kernberg's in his 90s, I think. He's part of an older guard. He's part of an earlier way of conceptualizing some of this stuff, and no less valuable. But I don't agree with everything he's got to say anymore. So, but thank you for the contribution. Okay. Well, let's see. I think I'm going to go to 4:00 my time. So just about 6 more minutes here. Let's see. What prognostic indicators do I use to assess treatability and overall prognosis? Somebody who's really heavily externalizing, it's not a good, it's not the best prognosis. Somebody who, if there are high levels of paranoia, it's not the best prognosis. If the personality organization is, if it's just like really severe personality disorder, it's not the best prognosis. And that's because it's just really hard for somebody who's, you know, in that really low borderline range, or even the high psychotic kind of part of the spectrum. It's really hard for somebody like that to hang with the treatment process. And it's hard to establish an alliance, like a consistent treatment alliance. It's not impossible. You know, I've got some folks in my caseload who, you know, who I would say are severely disordered. And what I find is that the quality of therapy is notably different. And I feel much more restricted in terms of how I can show up in that treatment relationship, in that dyad, right? There are things I can't say. There are interpretations I can't make. There are ways that I need to be very mindful about how I'm showing up so that I don't inadvertently trigger a severe trauma response that will be disorganizing and will, you know, cause more severe symptoms to emerge. So, you know, so that's hard work. It's tough. It's what's hard about it is getting through it, right? So let's say it's going to take, I don't know, this is a shot in the dark. Let's say it's going to take 2.5 years of regular meeting to get to a point where the person is able to tolerate me, you know, knowing knowing certain things about themselves, right? Without completely decompensating and hurting themselves, or, you know, right, or leaving therapy entirely or something like that. If it's going to take that long, well, that's that many opportunities then for me to screw that up, right? And for or for circumstances to just develop where an enactment that's therapy ending becomes inevitable, or for something in their life to happen that just sends them off the deep end, and now there's a flight from treatment, right? And now they're gone, and I never hear from them again. The longer the window, you know, in treatment where it's going to take to go from that place to a more stable place, the more likely it is that treatment is going to end before we get there. And that's tough. That's really tough. This happened fairly recently, where I had a patient that for the longest time I was just like, what's happening? You know, what's happening here, right? It was the best I could do to just sort of be there. The person couldn't tolerate me saying just about anything. And so I was just trying to hang in there, and we had just started to get to this place where there was a little bit of reflective capacity, and we could kind of talk together about, you know, like what seemed to be going on. And it was right when we got there that this crazy thing happened where they showed up for therapy at a time that we weren't scheduled, and I was in another session, and so I couldn't respond. and they were like having like a small crisis about it. And then I never heard from them again. I reached out afterward. I was like, hey, this is what happened. I think you got the wrong time. Like let's talk about it. Gone. Never heard from them again. So that's the kind of thing that happens. It's not that it's not treatable. It's that there's just things can be too erratic to be able to cross the finish line. So yeah. Okay, I'm going to take one more, and then I'm going to call it a day. Let's see. Somebody mentions hedgehog's dilemma here. That just means it's like the closer we get to somebody, the more they hurt us and we hurt them, and then we back off a little bit, but then we feel alone, and so we want to get close again, back and forth and back and forth. It's really kind of like a story of human relationships. A lot of people talking about just amongst themselves here, trying to see if there's another question. Okay. Life fan, what would you advise to a narcissist who wants to end her life because of her failures? I feel like I deserve to die because I'm not perfect. Well, I guess what I would say to you, life fan, is that you're not your failures. As my dad used to say this to me, he'd be like, "You're not a human doing; you're a human being," and it's true. It's true. I didn't appreciate it at the time, but now I do. And as a father myself, I look at my own kiddos, and I think I've seen this. I've witnessed this, the development of this soul, this being, since they came into the world up till now, and there's absolutely nothing that could make me not love them. There's nothing they could do, no way they could fail that would change the intrinsic goodness that I see in them. And I feel like that's just a matter of my privileged perspective, having witnessed their entire life. And I feel like it's true for all of us, right? You're not just the things that you do. You're all the different. You're so much more than that. And in the entirety of the universe, right? There's only one you, only ever has been, only ever will be. You're immeasurably precious in this respect. And I really feel for you, and where you're coming from right now. And gosh, so I guess my advice to you is to, when you feel like this, to reach out. If you're in the United States, call 988. That's the suicide and crisis hotline. It's free. They're there 24 hours a day, and they'll talk to you. They'll talk you through it. But if you're not, here, if you don't have access to something like that, um, reach out, right? Whether it's to a doctor or a therapist or a trusted friend. Don't be alone with these feelings. Communicate them to somebody because you matter. You do. You may not be able to see it, and the things about you that you feel are bad or wrong, or they might take up the whole screen sometimes. But you're so much more than your mistakes. And ultimately, I feel like this feeling that you shouldn't live, or you don't deserve to live because you've made mistakes or because you've made failures, is itself evidence of your goodness. That you want to be better. That and I think that part of you deserves to live. And by that I mean it deserves to. You deserve to live. And gosh, I feel like I'm kind of tripping over my tongue here because I don't know you, and I don't know your situation. But I really hope that you don't do anything to hurt yourself. And I say this as somebody who's lost somebody to suicide, and that person couldn't see their own value, and they felt like they didn't deserve to live, and there are a lot of people with holes in their hearts now because that person took themselves away, and they didn't have to. It didn't have to be that way. And I wish it wasn't that way. Anyway, my best to you, and I hope you're able to get the support that you need. Okay. Well, that was a sort of a heavy one to end on, but listen. I often say on my channel and in my videos that suicidality and NPD is a real thing. And this is a form of mental suffering and distress that can be incredibly painful, and people with NPD are absolutely at risk for suicide. And it's part of what is so agonizing to me when I go online and I see all this bullshit, all these channels that are just spewing garbage out into the world, and indirectly contributing to this kind of thing. I wonder how many times this person has looked online for some help, and what they've gotten back is just pure, straight up toxic shit that contributes to their feeling like they don't deserve to live. I can't. I feel like it is so irresponsible. I feel like it is so unethical for people who have any kind of mental health training to be putting that out into the world, when they should know that there are people like that individual who are absolutely at risk. Anyway, I don't know. It's why I started this channel, and I just can't see past it. Okay. Anyway, thanks for being here today. Abrupt transition. Thank you for being here today. And a couple of announcements I want to make. I've had a full waiting list for a long time And it's taken me a while, but I've finally been able to onboard 2 psychological associates who will be working under my license. I will be training them in my approach and supervising their work. Both of them are pretty close to getting their doctoral degree in psychology. They should be getting their doctorate by the end of the summer. And they're already registered as psychological associates in my practice. So they'll be taking new patients. And right now, they can work with anybody in California. So if you're located in California and you're interested in receiving some therapy for a reduced fee, then please reach out through my website. It's at www.healnpd.org. And I'm hoping to ramp them up to full caseloads in the next few months so we can help more people. So that's one thing. Another thing I wanted to talk about is that I've got a Substack that I just started. And so you can find that. It's called Heal NPD, as you might imagine. I have written versions of some of my videos there, but I also have like novel articles, like unique content that you can only find there, as well as this new thing that I'm starting. It's good. The first one's going to be published tomorrow. It's called Ask Dr. Ettensohn. It's sort of like this, but in written format. Folks can send in their questions, and I will respond to them. Not all of them, but select questions in written form on my Substack. So it's kind of like a recurring feature there. Yeah. Okay. Thank you all for being here. And sorry, I'm